There is a bidirectional relationship between non-alcoholic fatty liver disease and type 2 diabetes. Does diabetes affects the liver function first, or the hepatic impairment is responsible for the metabolic syndrome like diabetes? To guide us more and more about this, we have our next speaker with us, Dr. Uday Chand Ghoshal, former HOD, SGPGI MS, and currently attached with Apollo Hospital. And to chair this particular session, I'd like to invite Dr. Dilip Todi and Dr. Somnath Mukherjee, two of the father figure of gastroenterology.
Sorry, later block. Slide is there.
I'm on the slide. Slide.
It is my privilege to introduce Professor Ghoshal. He is one of us, and he has come back to Calcutta from SGPGI Lucknow, where he was head of the department of gastroenterology. He has numerous papers in both national and international journals, and he is a member of Rome Foundation, a prestigious Rome Foundation. We are grateful to have him here, and I'm sure he is going to enlighten us on this interesting topic. Professor Ghoshal.
Thank you. I must thank the organizer of this meeting for inviting me. And in fact, in a physician gathering, this is the first time after coming back from Lucknow to Calcutta. So I'll be talking about non-alcoholic fatty liver disease, chicken or egg. Now let me tell you, the name of non-alcoholic fatty liver disease is gradually being changed. Now we are calling that as metabolic syndrome associated liver disease. And you all know what is metabolic syndrome. Of the 5 features, if any 2 are present, these include obesity, fatty liver, hyperlipidemia, hypertension, and diabetes. This is metabolic syndrome. So metabolic syndrome is a metabolic disease. Now we gastroenterologists, because we look at the liver, we give a lot of importance to it. But obviously, it is a systematic problem in the whole body. This is alcoholic liver disease. But if he has not been taking alcohol, but still has fatty liver, something akin to alcoholic liver disease, this will be called as non-alcoholic fatty liver disease. Now they are calling as NAFLD. Now initially, NAFLD will start like fatty infiltration in the liver, but they may have increase in the SGOT and SGPT, suggesting that this fat is no more innocuous, but is causing inflammation in the liver, and this will be called as NAS, non-alcoholic steatohepatitis. Now you will ask me, how common is this? It is very common, as you can see from this chart. All over the world, non-alcoholic fatty liver disease is very common. But look at Indian map. In India, it is much more common than many parts of the world, because typically we eat a lot. Many of us take a huge amount of carbohydrate. We have really a truncal obesity, and that is the reason why non-alcoholic fatty liver disease is much more common in India than in many other countries. And in fact, if you look at the literature, non-alcoholic fatty liver disease has been increasing over the years. Obviously, what chart I am showing here are they public, based on the publication, based on the epidemiological studies, which clearly shows that if you look at the literature, NAFLD has been increasing. Now, if somebody is a diabetic, does he have more NAFLD? Yes. Look at this chart, and this chart depicts frequency of NAFLD among diabetic subjects, and in some of the studies, almost half of the diabetic have fatty liver. So if somebody has diabetes, you can imagine 50 to 60% of them would be having fatty liver. Now, is that important? I'll tell you, yes, it is important. Usually these patients are asymptomatic. Typically, somebody got an ultrasound done, an ultrasound showed fatty liver. LFT may be normal or abnormal. Patient may be obese or may be lean. That means there is a variety of NAS which is called lean NAS. And interestingly, even lean NAS patients also have actually insulin resistance. LFT may show more AST, that is SGOT, than SGPT. Alkaline phosphatase may be raised also, but bilirubin is usually normal. Now, if you look at the ultrasound, what will you find? There is a hypoechoic liver, and gradually you cannot identify the vessels. For example, the branches of the portal vein, you cannot identify them. Maybe there will be effacement of the diaphragm. You can't identify separate diaphragm. Based on that, people have said non-alcoholic fatty liver disease can be graded. There is an ultrasound grading I'll talk about later. And look at that, healthy liver, almost 20% of us would be having fatty liver disease. Even if you look at data from West Bengal, a study was done in Birbhum where they found almost 7 to 8% population of Birbhum had non-alcoholic fatty liver disease. Now this non-alcoholic fatty liver disease, about 15 to 20%, that means 1 out of 5, will progress to NAS. So initially it was only fatty infiltration, subsequently SGOT, SGPT rises. And later they can develop cirrhosis, sorry for the mislabeling there, this is cirrhosis, the fourth one. They can develop cirrhosis. And how commonly cirrhosis develop? Among NAS patients, 1 in 5 develop cirrhosis. Obviously, hepatocellular carcinoma is much less common, to the tune of about 2%. So 2% patient due to NAFLD-related cirrhosis can develop hepatocellular carcinoma. This is natural history, but the natural history may be modified by another important organ which can kill the patient more abruptly, that is heart attack. So all patients of non-alcoholic fatty liver disease, even without diabetes, has a greater risk of myocardial infarction because of the metabolic syndrome. Second, we gastroenterologists typically look at what is the degree of fibrosis. So one, you see, there is fat in the liver, transaminase is normal. So this is only fatty infiltration. Second could be fat which has started necroinflammatory activity, SGOT, SGPT is raised. Now in that patient, obviously we call NAS. But we are interested in degree of fibrosis. Because if fibrosis is more, this is an alarm feature which I'll show later. So who develop fibrosis more often? Who are the one who progress? Those who have diabetes plus NAFLD, those whose BMI is more than 30, those in whom AST is more than ALT, certain races, and those in whom ferritin is high. Because iron is bad for liver. Anybody who has excess iron and ferritin is bad for liver. Even we know in hepatitis C patient, if somebody has a more iron, the hepatitis C doesn't respond to the drug such as interferon, which used to give in the past, now we don't give anymore. So what happens is iron is bad for the liver, and those who have high ferritin are the one who will actually have more fibrosis. Now the factor predominantly are genetic, that means the individual, because the insulin resistance depend upon the genetic makeup. We all know diabetes has concordance rate of as high as 60%, and it may be even higher in certain groups such as MODY or maturity onset diabetes of young. Genetic factor. Second important factor is environment, that is your diet, your exercise. And third important factor, which I will talk about now, is gut microbiota. So diabetes, cardiac disease, their origin may lie in the gut. Now, two important factors I will depict to you. One is insulin resistance, which is very systemic problem. Now the cells, even though beta cell is releasing enough insulin, but the peripheral body cells do not utilize that insulin. And we all know as we become obese, our insulin resistance increases. What does insulin resistance do? It leads to lack of peripheral utilization of the glucose. So the excess glucose may go to the liver. Obviously, subsequently it may be converted to glycogen, or even it may lead to fatty acid, and the fatty acid will cause problem. What are the problems? Look at the fatty acid, sources of triglyceride in the body. One source is which goes to the liver. So if you look at non-alcoholic fatty liver disease, they have excess fat in the liver. Where from this fat came? Triglyceride came from circulating free fatty acid. So if somebody has insulin resistance, he produces more free fatty acid, this free fatty acid will go to the liver. Second thing is excess carbohydrate diet that will be converted into fat, so lipogenesis. That's why when somebody takes a lot of carbohydrate, he develops a paunch here, and this is fat. And this fat came from carbohydrate because of the conversion. Interestingly, the triglyceride that comes in our liver, only 14% is coming from the diet. So if you just restrict the diet from the dietary fat, you are not going to do any wonder. You have to exercise, you have to reduce your insulin resistance. Now, what does this fatty acid do? They will undergo beta oxidation in the mitochondria. We all know that in mitochondria, inner cristae, they will metabolize the fatty acid and will produce about 32 ATPs. But more than that, they will be esterified to make triglyceride, and this triglyceride may circulate in the blood, and if you measure the blood triglyceride, they will have high triglyceride, or they will be re-esterified and will accumulate in the liver. So the origin of the fat in the liver is from the blood, from the re-esterification of the free fatty acid, which is because of the excess carbohydrate, excess glucose. What is the other source? The other cause for the fatty non-alcoholic steatohepatitis is second hit. The first hit was metabolic defect, insulin resistance. The second hit is given by bacteria. So it is the gut bacteria which gives the second hit because it results into the inflammatory activity. Initially it was fat accumulation, this was bland fat. Now what happens is there is bacterial translocation, there is an elevated level of PAMP, DAMP, and what are these? That PAMP or DAMP are the product of tissue damage by the bacteria. And interestingly, those people who don't drink, they get alcohol in their portal vein. Can you imagine? That means the fellow doesn't drink, he took some rice, and the rice is converted to alcohol. There is an excess of the alcohol in the portal vein, and it goes to liver and lead to fat in the liver. Now, therefore, bacterial overgrowth is very, very important. These are two studies. One of these are from our group, that patient of non-alcoholic fatty liver disease have bacterial overgrowth, and some of them have bacteria which produce alcohol. This is an elegant study which proved this concept, that the sugar control is not entirely related to exercise and the diet, but also gut microbiota. Because of the shortage of time, I will not elaborate on this interesting study. So what is happening is, when we are eating, Some of the carbohydrates are malabsorbed. For example, if you take a complex carbohydrate, only 90% gets digested and absorbed, 10% is malabsorbed. On the other hand, if you take refined rice, about 95 to 98% is digested, only 2 to 4% is malabsorbed. But this malabsorbed food is actually metabolized by the carbohydrate, by the microbiota in the gut, produces short chain fatty acid, and short chain fatty acid gets digested. Now, how will you investigate? We'll do an ultrasound. If it has not been already done, we'll do an ultrasound. The ultrasound also give you grade of fatty liver, grade 1, grade 2, and grade 3. Typically, grade 3 is the one where diaphragm and liver become similar in echogenicity. The radiologist cannot identify. Whereas grade 1, you can clearly identify diaphragm and portal vein. We also do a MR spectroscopy. MRI have a beautiful technology where we can measure the amount of chemical in the body non-invasively. We'll do an MR spectroscopy. Do you need to do liver biopsy? Nowadays, the recommendation of most international bodies such as the Hepatology Organization of US and American College of Gastroenterology say liver biopsy is not mandatory. You can do a lot of things non-invasively. So this is the flow of all the investigation. I'll elaborate on two here. One is FibroScan and other is FIB4. FibroScan and FIB4. So what is this FibroScan? You send an ultrasound wave from outside. Now, depending upon the stiffness of the liver and fat content of the liver, the ultrasound wave will deviate from their path, and we can know that how much is the stiffness of the liver, how much is the fat content of the liver. So in FibroScan, typically we get the fibrosis by kilopascal unit, that is stiffness, that is a measure of stiffness. And you can see if somebody's stiffness is up to 2 to 7, that basically means it is F0, F1 fibrosis, hardly any fibrosis. F2, 7.5 to 10. F3 means fibrosis has become more, 10 to 14. And above 14, practically it is very stiff liver. That means the fellow has already developed cirrhosis. From the CAP score, you can determine how much is the fat content. Second is in MR spectroscopy, we can measure the amount of the fat such as different lipids present, and these are the two investigations. One is FibroScan, another is MR spectroscopy. The fibrosis 4 score actually takes into consideration multiple things such as your age, such as your AST, such as your ALT, and it gives how fibrotic the liver is, how steep the liver is. Because non-alcoholic fatty liver disease, only fat present with normal SGOT, SGPT, you don't have to bother much, only little exercise, control of sugar, reduction of insulin resistance is enough. Now if NAS has set in, we have to be cautious, we have to be more aggressive. If the fibrosis has become advanced, we have to be very aggressive. Now, what is the cornerstone of management? Cornerstone management is lifestyle modification. Lifestyle modification means a lot of exercise. Eat what you need to eat. Just don't eat for the tongue. Eat for your whole body. So if you eat for tongue, you will overeat, and that will be bad. Eat that much what you can spend through exercise and your work. Now that will reduce insulin resistance. Second is when people remain obese, they cannot control, we can endoscopically reduce obesity. For example, we can place a balloon inside the stomach, his appetite will get reduced, or we can use the other technologies. For example, we can make a hole in the stomach and then he eats, but he vents out all the food from that tube after the eating is done, so that tongue is satisfied, but excess food doesn't become toxic to him. So these are all endoscopic treatment which I will not elaborate. There are bariatric surgery, but let us talk about some drugs. The drugs are not many in non-alcoholic fatty liver disease. What I do in my patient is, if I find the fellow has glucose intolerance and is little obese, I'm happy. You know why? I have better control on him because I know if I prescribe metformin for his glucose intolerance or diabetes, metformin is a wonder drug. It reduces obesity, it reduces insulin resistance, it reduces fatty liver, even people have shown it prevents colon cancer, it prevents coronary artery disease, all good thing except some GI side effect. So if patient can tolerate metformin, nothing like it. Now what are the other drug? People have tried vitamin E, but vitamin E has toxicity. And it is said that unless liver biopsy showed certain degree of steatohepatitis, you are not supposed to give vitamin E. Now, ursodeoxycholic acid trial was not found successful, therefore do not give it. I know a lot of people give it. Obeticholic acid has been found successful in some studies. For example, Arun Sannal has done a lot of randomized control trial. But let me tell you what is the problem of obeticholic acid. We all know that bile acid is the one which reduces lipids from our body. So because cholesterol is metabolized to bile acid and the bile acid goes with the stool, that's why we don't develop hyperlipidemia. Now what happens is there is in ileum, in our ileum, that is later part of the small intestine, we have something called FXR. Now, obeticholic acid is an FXR agonist. So therefore, this FXR stimulation by obeticholic acid leads to FGF9 production, and FGF9 competitively inhibits further production of bile acid. So problem there is that if you reduce bile acid production, what will happen? Lipid will become higher. So you try to protect the liver by giving obeticholic acid. In return, you damage the heart. That is the reason why obeticholic acid has been banned from using in non-alcoholic fatty liver disease. So this is my algorithm. If you got NAFLD, just look at the risk score. Then if you look at only innocuous fatty liver, don't worry. Just exercise, lifestyle modification, diet restriction. If you find that there is transaminase elevation, there is also some degree of fibrosis, we have to be particularly careful. And people have shown that if you reduce your body weight by 5%, actually you benefit the liver. So therefore, exercise, reduction of the body weight. Metformin is a wonder drug, though this is not typically recommended for NAFLD, but those who have glucose intolerance, diabetes, and if he has fatty liver in addition, the choice is metformin and not one of those other drugs which stimulate insulin secretion, because metformin increases insulin sensitivity and also it reduces body weight. Thank you so much. Now question is non-alcoholic fatty liver disease the egg or the chicken? I would say they are all both related. We don't know what is egg, what is chicken. It is a systemic metabolic disorder related to insulin resistance and the gut microbiota. So both are egg, both are chicken. Thank you so much.
Thank you very much, Professor Ghoshal, for a very lucid talk. I'm sure there will be lots of questions from the floor.
Yeah, saroglitazar has been approved for use in non-alcoholic fatty liver disease in India by DCGI, and in fact, this is another drug that we have been using. So we have been using metformin where it can be used, and second, we have been using quite often saroglitazar. Huh? Pioglitazone can also be used, but if you ask me, my preference is between saroglitazar and metformin.
One thing, being a devil's advocate,
Yeah.
saroglitazar has been approved by DGCI here, but one has to understand that it still hasn't gone past the phase 3 trials.
Yeah, that's right. That was like, suppose how it is approved, we don't know. But what happens is sometimes some approvals are rapid. Like in Corona, we know lot of drugs were approved by FDA quite fast track, and we later realized those were not great drug. Maybe because NAFLD you don't have much to offer, truly speaking, and that's why it was approved. But again, more data are needed on this. Personal experience, whatever limited experience I have with the seroglitazar, I would say not great. My personal experience has been very good with reduction in the weight, lot of exercise, and use of metformin.
Sir, put some light on the improvement of gut microbiota, if at all there is any.
Yeah, I know. I did not show that figure because of shortage of time. Actually, if somebody has bacterial overgrowth, if you treat it, theoretically speaking, it should benefit, but there is no study. Now, second is people have tried probiotic. I know from PGI Chandigarh, there was a study published possibly in gastroenterology, yes. So that was positive, but again, probiotic has a very mixed result. I would not bank on those for treatment of NAFLD. Cornerstone is exercise, weight reduction, improvement in insulin sensitivity, and maybe metformin will be helping that also. This is cornerstone. I had patients who were little obese, SGOT, SGPT 370, 380. With exercise, they lost weight, their appearance changed, SGOT, SGPT became below 45. So I would stress on exercise, weight reduction a lot.
Professor Ghoshal.
The question, since the bacterial overgrowth was being talked about and it's a new thought, we were not so sensitized to this hit. Nowadays we are using a lot of rifaximin for good or bad reasons. Is that, does that have any effect on microbiota?
Yeah, rifaximin changes microbiota, there's no doubt. But the problem is this change is only temporary. The change lasts for 2 to 3 months, and then the same bacteria repopulate again. So therefore, NAFLD is a long-standing problem. Now it is related to metabolic problem, obesity and all those. There, just changing the microbiota for 2 months, 3 months doesn't really make sense. I would say if rifaximin is indicated for something else, you can always use, but not for NAFLD.
Udada, do you advocate screening for NAFLD in all diabetics?
Huh?
Should we be screening all diabetics for fatty liver?
Yeah, I think so. You see, if any diabetic comes, I would say getting an SGOT, SGPT would be routine. So must do an LFT. And I think most of your patients, you will like to do an ultrasound, I'm sure. If you are not doing, even if you screen by SGOT, SGPT, you will pick up at least NAS. Because NAS is really something which you cannot ignore, because almost 20 to 40% can progress to cirrhosis. And not recognizing NAS is not a good thing. So I would say everybody should have a simple ultrasound and SGOT, SGPT. If you find there is a cost constraint, at least do a SGOT, SGPT.
What is that? In the complex carbohydrate, 10% is not absorbed, and short-chain fatty acid is produced, you told. And what is the function of that short-chain fatty acid?
Yeah, very good. So this short-chain fatty acid is typically produced in the right colon by the microbes. And this short-chain fatty acid include acetate, butyrate, and propionate. Now they are nutrient to the colonocyte. So the colon epithelial cell, they require the food obviously. So the colonic epithelial cell derive nutrition from short-chain fatty acid. This short-chain fatty acid stimulate sodium chloride absorption from the right colon and secondary water drag. So therefore, a lot of water, sodium and chloride is absorbed because of the promotion by short-chain fatty acid. And third thing is, this is the method by which we conserve calorie. That's why people can have gut microbiota, which keep on conserving calorie. They will eat cucumber, but still they become obese. They will say, Doctor Saab, मैं तो खीरा खा रहा हूँ, I am only eating শসা তাও আমি মোটা হয়ে যাচ্ছি, that is because he has different microbiota. And that is what I wanted to show in that study which Iran Alinov did. He is from Israel. And he showed that it is not only the diet that you eat which determines your blood sugar elevation, but also the microbiota that you have actually determine blood sugar elevation. That is a fantastic study.
Can we keep our gut microbiota healthy by taking a lot of non-alcoholic carbohydrates to diet?
Yeah, you are right. But only thing is that you can keep microbiota healthy by taking those. Because what is a healthy microbiota? More firmicutes means more healthy microbiota. But if you have more firmicutes, you will conserve more calorie and you will become obese and you will have bad blood sugar. So for a diabetologist, you should not have a lot of firmicutes. For others, yes, we should have more firmicutes. So the fiber typically promote the growth of firmicutes, but the firmicute excess will also conserve more calorie. But yes, people have shown that if you change the diet for even 7 days, from predominantly non-veg to veg, you have a change in the microbiota from less firmicutes to more firmicutes. So it can be done.
So, as you mentioned, the gut microbiota is very important for development of fatty liver. So, what is your opinion regarding FMT, for FMT, fecal microbiota transfer, for treatment of fatty liver disease?
Yeah, you see, FMT has not been recommended for non-alcoholic fatty liver disease. I know a lot of studies are going on in India also, ILBS and Lakeshore Hospital, which is now closed, from Abby Philip and from Dr. Sarin. But those are all experimental. So today, do not do fecal transplantation for non-alcoholic fatty liver disease. If somebody is doing an experiment, fine, but that is not the treatment. So only in recurrent Clostridium difficile infection, it is approved that fecal transplantation can be done, no other indication.
In the interest of time, I think we have to wind up this session. Thanks very much to Professor Gosal for an excellent talk and excellent discussion after.
And it's time to facilitate our speaker, sir. I would like to request our chairperson to please felicitate him.